All right, good afternoon, everybody. After many technical difficulties on Tuesday night, we are back with our planned conversation with Dr. John Willen, who is an infectious disease expert for 37 years, retired now, and getting set to chat with us today about the COVID-19 coronavirus pandemic and talk a little bit about Civil War history and how those two things are really tied together. My name is Jake Wynn. I am the Director of Interpretation at the National Museum of Civil War Medicine. I'm joined by my Executive Officer, David Price, Executive Director of the National Museum of Civil War Medicine, and Dr. John Willen, as I said, expert in infectious diseases. And what we're going to do today is just kind of have a conversation about history, about the current pandemic we're experiencing, and how those two things are related. This fits into some efforts at the National Museum of Civil War Medicine that we have been endeavoring to do since the start of the COVID shutdown back in March, and that is to bring our museum online. Unfortunately, because of the public health menace that we are all facing right now, our museums cannot be open to the public. And so we flipped a switch and went to online. And so now we've been doing Facebook Live videos, YouTube videos, new blog content on our website, civilwarmed.org. And we've been focusing on sparking conversation and relating the experiences that we're having now with the experiences of the Civil War and finding hope through history. And this conversation is one that we have all been very excited about in tying in the Civil War medical experience to what we're experiencing right now and looking at how some of the innovations from the Civil War are impacting our current public health crisis. So that's what we're going to do today. I do want to throw in, and we've been doing this throughout many of our videos, a pitch for the National Museum of Civil War Medicine. We are a nonprofit organization, member supported. And so in order to do these programs, we do need support. We don't have admissions coming into the museum right now. So we are encouraging people to go to our website, civilwarmed.org/support, and become a member of the National Museum of Civil War Medicine. Get lots of great perks, including once this is over and you can actually come and visit museums again, you get free admission to the museum, to all three of our museums, and you have these knowledge that you are supporting a wonderful organization that is finding ways to make history relevant and to talk about history and how it impacts us today. So you'll find that information on our website, and I'll also be dropping it into the comment section on our video. With the comment section being said, if you have a question at any point during this conversation, please drop it into the comments. Let us know where you're from, where you're watching from, and if you have any comments and questions, just drop them in there, and I will be monitoring those, and we'll be interjecting some of those questions into our conversation. At the end of the conversation, too, we'll have a short designated Q&A time with some of those questions as well. So with all that being said, I'm going to turn it over to David Price, Executive Director of the museum, and get us started with this conversation and the origins of this presentation and with the topics that we're going to cover today.
Yeah, thanks, Jake. And I'm very excited to do this. Once I discovered John's Facebook posts on the coronavirus and his updates, it made me realize a couple things. Number one, it seems like you have to go to so many sources, whether television, internet, radio, in order to get a comprehensive idea of what's going on with this pandemic. And with John's post, with your post, Dr. Willen, it was just refreshing to have accurate information. So that's kind of what started this. And then it seems like each day we're hearing about something new in response to this that reminded me so much of what happened during the Civil War. And, then as time goes on, people are kind of getting down in the dumps and stir crazy. And it made me realize there's hope in history if we learn from it. So that's kind of what the impetus of this interview itself was. So to start with, John, talk about Dr. Semmelweis, because you call it Semmelweis Updates. And I encourage everyone to look him up on Facebook and follow him for these updates. And just talk about the good doctor, and then we'll talk about some of the main questions that you get asked over and over again.
Well, thank you, Dave. And indeed, I call it Semmelweis, and part of it is because I think Jake one time early on put something on Twitter. He said, "Do like Dr. Semmelweis and wash your hands," which set off a light bulb in my mind, because I have lectured on Semmelweis. He was a screensaver on my computer. He was one of my heroes. And so I now actually, it's evolved into now what I call a project, thanks to you also, your term. And so I now am calling it the Semmelweis COVID-19 project updates long term, but that's what it has become a project. And getting to Dr. Semmelweis, of course, this is Ignaz Philipp Semmelweis, who was who's actually Hungarian, but his obstetrician, who practiced in the General Hospital in Vienna in the 1840s. And Semmelweis, there were two wards in this two obstetric wards, one run by medical students and their professors, the other run by nurse midwives. And there was a scourge back then called childbed fever, puerperal sepsis. It's still around, caused by streptococcus. And the incidence of that NAD was over 10% in the medical student ward, and was around 2-3% in the midwife ward. In fact, the people, the women knew about this, and they would literally scream and yell to stay away from the medical student ward. They have the babies on the street, so they would actually could avoid going into that ward. They call them street births. And so Semmelweis observed that the medical students in the morning did autopsies on the women who died of childbed fever. In the afternoon, they go up and examine the pregnant women. And he had a friend who was doing an autopsy on a woman who had died, cut his finger, died from sepsis. And when they autopsied him, Semmelweis did the autopsy, the findings were identical to the women. So he's ultimately put 2 and 2 together and realized that the hands of the medical students was transmitting this, whatever agent it was, to the ward. So he decided to have a basin with chloride of lime solution. It's basically bleach. It's ironically to the connection to today, it was a dilute bleach solution. And he literally positioned himself at the door to the ward, would not let anyone in until they've washed their hands. Once this practice was instituted, the rate of childbed fever dropped to comparable to the nurse midwife floor. And ultimately, after he also instituted the practice of washing the instruments in the bleach, went to 0 at one point.
Wow.
So he's vindicated. However, the physicians in the hospital refused to accept basically what he was saying, because if they did admit to him being correct, they have to admit that they're the problem and they're killing their patients. Ultimately, this was in 1847. Ultimately, by late 1849, 1850, he was essentially ousted. He wanted to apply for a higher position, and he was asked not to. So he had to return to his native Hungary, where he went to a hospital there, put the same practices in with the same results. He unfortunately developed mental problems and died in a mental institution of sepsis, by the way. The same thing he wrote about. And the funny thing is, he died July 13th, 1865. My birthday happens to be July 13th.
Good grief. I mean, it's like they washed their hands of this guy. I mean, pardon the pun.
That's a good point. Now,
yeah.
His mental problems, they think, could be related to the fact that syphilis was a common problem in obstetricians back then because of the work they did with prostitutes, and they transmitted it through examining prostitutes with syphilis. That's one theory of why he went insane, other than the fact that he never was accepted.
Yeah.
So now there's a statue to him. It's called Savior of Mothers in the medical school in Budapest. In front of it, there's a statue of Semmelweis with a woman looking up in awe at him. So he has now, his home's a tourist attraction. Dr. Semmelweis has indeed been vindicated, but he's sort of considered the father of hand washing and to prevent the spread of infectious diseases.
Well, you know, that story reminds me of the story of Hammond and the use of mercury. It's like anybody in the medical community that comes out with an innovation that works, you know, sometimes ends up a martyr.
You bring up Hammond, absolutely. He'd been traveling and he ran into a guy who said, you know, that mercury is a poison. It was another physician, but the medical community doesn't really realize that. So Hammond got the idea, let's ban you know, tartar emetic, which is antimony, another poison, and calomel, which is mercury, from the union supply table. For his efforts, he was basically court-martialed on trumped-up charges and dismissed as Surgeon General.
Yeah.
Now, ultimately, Hammond was another one of these. He was sort of a my way or the highway kind of guy. His personality got in the way at some level, but he did ultimately get himself vindicated through the court, you know, the military court system in the 1880s. So Hammond, of course, Hammond is now justified, is now rehabilitated because he was totally right.
Yeah, and it kind of, both of those guys, the stories of Surgeon General William Hammond in the Civil War and Semmelweis, it makes you really appreciate the skills that Dr. Tony Fauci has.
Well, yeah. Now, one of my heroes in medicine, besides Dr. Semmelweis and Dr. Hammond, is Dr. Fauci, who I first met about 40 years ago at an infectious disease meeting. I always joke, I knew him when he had dark hair. And I heard him speak, and these were the early days of the HIV epidemic. And that's really where he sort of made his bones, you know, in the HIV. And I heard this guy give a lecture, and I said, that is the smartest doctor I've ever heard. And to this day, I agree with that. And he's in a very difficult position. We're not getting political here, but he's in a very difficult position right now, as anybody who observes what's going on can observe for themselves.
Well, I mean, 100%. You know, to me, this is about leadership, and you know, with Dr. Fauci and the scientists, you need the health community to be the leaders and the scientists to be the leaders in this. And you know, the same thing happened in the Civil War when, and this is, you know, drawing these comparisons to the Civil War. The method to the madness is to really to let people know that we've faced this kind of crisis before. It wasn't a pandemic, but you know, you look at the beginning of the Civil War, the army was not prepared to save soldiers; they were prepared to kill. Nobody thought it would be a long conflict. You know, as you know, John, the first Battle of Bull Run, folks from DC are going out in their carriages with their picnic baskets to watch the show. And then all of a sudden, shooting breaks out, shocker. They run away. The wounded lay on the field from 48 hours to 2 weeks. Many had to just walk their way back to 20-some miles to DC, where they had not prepared to set up hospitals and were not prepared for the influx of patients. So what happens? And so, you know, today we see these numbers of 700 dying in New York, and it's horrific. The same thing happened in the Civil War. Thousands were injured and killed, and we just weren't mentally ready for it or systems ready for it. So then what happened is kind of what is happening today, is you've got Dr. Jonathan Letterman, who is tasked under Surgeon General William Hammond to come up with a system to bring order out of chaos, to deal with the number of casualties and to flatten the curve of all those wounded. So to me, Fauci is a modern day Letterman.
Well, in a way, you're right, and you bring up, of course, another one of my heroes is Dr. Letterman. But in the parallel of not being anticipating or not being, there's no way they could have been anticipating the number of casualties they would have to deal with. I mean, when the war broke out, there were 113 doctors in the U.S. Army, and 24 of those guys went to the South. So they had 89 physicians. By the time the war ended, they had 12,500 doctors serve in the Union Army. So that's how, and most of these guys had never even seen an amputation, let alone do one in civilian practice.
Yeah, and then so, how did they recruit those doctors? Kind of the same way that we're doing today, out of medical schools and out of retirement and out of their, country practices.
Yes, and they even indeed had a program called Medical Cadets, where they take medical students and put them into the general hospitals to boost the manpower.
Hey, so, one of the other things that I really, one of the things that strikes me is the fact that we're now seeing these first person accounts from healthcare workers, nurses and doctors. And you can tell these people are at the end of their rope and are having to mentally and emotionally come to grips with what they're seeing. And it really reminded me of Civil War surgeons who, just like you said, never had even seen an amputation, much less performed one. And then, as the writings of the soldiers and the doctors themselves, they sort of become numb to it in order to be able to deal with it. Can you talk about that a little bit?
Sure.
That translates to PTSD to me at the end of it.
Well, yeah, and of course they had their terms for that. They had nostalgia, which is extreme homesickness. They had DaCosta syndrome, which was another term from Joseph DaCosta, who described this. He thought it was organic, but he's basically describing PTSD. And I read a lot of diaries of surgeons, and a lot of these guys were really, just as you suggest, the mental and physical strain on them. We know of incidents of surgeons operating to the point of their hands swelling. They couldn't hold the saw anymore. I mean, one of the lectures I give is on Zabdiel Boylston Adams. He's the only doctor who has a monument on the Gettysburg battlefield. And Adams operated for 48 hours straight after the Battle of Gettysburg and then went blind. And we think it's hysterical blindness. I mean, if you ever want a concrete example of stress or the mind getting to somebody, this guy actually went blind after operating for 40. And this is the kind of thing we're talking about that happened.
Right. And, similarly today, this stuff could happen. I mean, when you've got hospitals overrun, you just pray for those healthcare workers to be able to deal with what they're seeing. The other part about the leadership aspect and Letterman and Fauci is you hope that, they'll learn something from this. And the tragic reality of the Letterman system is right after the Civil War, guess what America did? Immediately forgot his entire system.
Well, that's true. And the other tragedy is that even Letterman didn't invent that system. That was invented by Lou Ray, who was Napoleon's medical director with the flying ambulances, but it never translated across the ocean.
So history repeats itself unless you learn from it. So, the only hope is this system that we're putting in place today worldwide, the saving grace might be that the world has had to deal with it rather than just one country, so that maybe we'll learn the lessons and be prepared the next time this happens.
We certainly hope so.
Yeah.
And this thing, it's not like this was not predicted. We're talking just the pandemic in general. You'll hear politicians say, oh, we never anticipated anything like that. That's totally false. They just didn't want to listen. Again, I'm not political, but they had people in the White House who were involved with this. And both parties did this. They got rid of these people because they said there's no pandemic going on. What are they going to do?
Yeah. Well, and here's another thing that struck me too is you see that tent hospital being set up in Central Park by a civilian organization, which then reminded me of the partnership between the Sanitary Commission and the government back in the Civil War. I mean, those are powerful partnerships.
Yeah, and we have the Red Cross today, which is sort of the Sanitary Commission was sort of a forerunner to the Red Cross. So yeah, absolutely. And of course, there was a Civil War hospital in Central Park. It actually wasn't a tent hospital; it was in the building. But there, up on 102nd Street, there was actually a Civil War. It was called Central Park Hospital during the war. So the second time there's been a hospital in Central Park.
So I'll jump in here, gentlemen. We have some. This is great conversation. We do have people commenting in from around the country. Thank you all so much for tuning in. I do have a question that I want to jump on as we're talking kind of about infrastructure here. It's a question from Chris. Let me pull it up here. And it is says Maryland is leasing 2 ice rinks for possible use as morgues. Is this erratic or a good call?
Well, like again, I always quote Dr. Fauci. He says you're better to be over prepared than under prepared. So I don't know that it's ever going to get to that. We do know in New York there you see pictures of refrigerated trucks already.
Yeah.
And so, you know, we don't know if it's going to get that bad. But so what? If you don't need the ice rink, that's terrific. But you're better off having something like that, at least in your contingency plans, than dismissing it. You know, a lot of that we're doing, people say things work out better. No, it's not that you didn't need it, it's that it worked. There are certain politicians who say, yeah, you don't want to get over prepared. No. If things get better, it's because it worked, not because we didn't need it in the first place. And it's interesting also when you point out with the military. See, I am also a docent at the National Museum of Health and Medicine, so I get all the military updates. The hospital in the Javits Convention Center in New York is being run by military people. Plus, of course, the Comfort and the Mercy that have been deployed in Los Angeles and New York.
I just got a clarification from my people on the inside that our governor here in Maryland, Governor Hogan, actually said that at this point they aren't considering ice rinks, but that it's not true. But like you said, it's better to at least have that. It's probably been talked about somewhere.
Well, that's right. That's what happens, is that they talk about it and then somebody puts it out that, oh yeah, that's what they're going to do. And it's just, when you're planning, if you're smart, you think of all the options. Hogan actually has been one of the better governors. We're not political again, but there's some governors who have been better at this than others on both sides. So
yeah, I agree. And it's interesting to watch. You can you can separate the good ones from the bad ones in a hurry when you watch their press conferences and you hear what they're doing. Jumping back to the temporary morgues and the refrigerated trucks and everything. One of the things that the Civil War did, we talk about Dr. Burr, who worked out of this a museum here in Frederick, Maryland, who was an embalmer. And embalming came back during the Civil War because it was the first time that death was occurring away from home in mass. So it changed the way America mourned their losses, because prior to the Civil War, as you know, John, people would pass away usually on their property or within a couple miles of their property, and family members would never leave the body until they were buried. There was you would often get a picture taken with your dead loved one, and that conflict where your son or your husband was killed hundreds of miles away meant you had to fill that mourning gap somehow, and embalming was the answer. We're seeing the same kind of transition, whether we know it or not. We're changing the way we mourn today, because now when somebody passes away, regrettably, you can't be near them for those final few weeks if they've got COVID. And then once they do die, even if it's of other causes, because of the social distancing, you're not able to be there to have that closure. And, it's pretty powerful, that shift.
You're totally right. And if people are interested in this topic more, I would recommend Drew Gilpin-Faust's book, This Republic of Suffering. It's an outstanding book describing death and dying in the Civil War era.
Yeah, Jake, put that title up, because that is an incredible resource, and we're living through a transformative time on a lot of levels. The other thing I was going to give you a chance to talk about is you've got a lot of. Let's get back to the current day, and right before we went on, I asked you the question that everyone is asking and no one gives an answer, but you gave me the best insight on it. Is realistically, how long are we going to be in this social distancing situation? And when, what's your best guess of when we'll be able to come out of it?
Right. And, on the blog, I have frequently asked questions, and that's number one. And of course, I always begin the answer by again quoting Dr. Fauci, who said, the timeline will be determined by the virus, not by us, and which is true. But having said that, there are certain things that need to be in place before this can be eased up. And again, you have two competing forces here, of course, and I don't diminish the non-medical one at all. And that is, the public health concerns versus the social and economic concerns, people out of work and what it's doing to the economy. And ultimately, people could die because of not being able to get access to their medicines for other things and so forth. Having said that, what I think needs to be in place, though, Dave, is number one, you need universal testing, or testing on demand available. You need the antibody test, which determines if a person is immune or not. We presume that's what it will show. And those two things are most important, for the simple reason is you want to be able to determine if it's safe to let people back. So if you have testing easily available, you can do it that way. We do believe that people shed virus. Nothing is precise, but the figure I've seen given is 10 days after the fever stops, then they stop shedding virus. The other one is with healthcare workers, they're demanding now, obviously it needs to be more stringent to go back to a hospital setting, two negative tests 24 hours apart. But also what the antibody test allows us to do is to determine prevalence, more of the background. People find out the people who are asymptomatic people with COVID. And two, obviously that they have evidence of recent infection immunity and they can go back. Having said all of that, it's not going to be flipping a switch. I think Fauci has even used that analogy. You don't flip a switch when the so-called curve is flattened. The term we're looking for is decreased cases and death. That's flattening of the curve. When that happens, you don't just flip a switch and say, go back to normal. You have to do this on a region by region basis. Where it's really flattened the most, where it's still going on. Everything, you have to take it on a case by case or a state by state or region by region basis. I mean, Dr. Fauci, if he had his way, I'm sure it would go on until a vaccine's available. That's the other part of the mix that he likes to talk about, is when will we have a vaccine, when we have a vaccine available in case the thing does come back. And the earliest we're looking at that is the early part of 2021 to have a vaccine in place. So I heard Dr. Fauci recently said people will never be able to shake hands again.
Yeah.
He actually said, and I think that's maybe a little extreme, but I know where he's coming from with that.
Yeah.
Ever again shake hands.
So it's from your description, it sounds like the key is going to be those series of tests that have to be developed.
Right.
And we have a good question here that I think is really just want to hit on, just because it's something that Dr. Willen mentioned. David, sorry to interrupt, but what does that mean, shedding the virus, Dr. Willen?
Okay, right. That means that the virus is still present in your respiratory secretions. And even that is not, and also it can be detected from the stool. So that's another place the virus is shed from the gastrointestinal tract. One of the problems with the testing, of course, using testing as a criteria, is when you have more advanced disease, the virus actually will move from the nose and mouth into the lower respiratory tract. So those tests that where you swab the nose and the throat, they could be false negatives actually, because it still may be present in the lower respiratory tract. It still may be present in the GI tract. One of the presentations that's sort of it's abnormal, but the Chinese report this now in over half of their cases was the presentation with gastrointestinal symptoms, especially diarrhea, but also nausea and vomiting. Those can be present. You know, I speak with my former partners and all the time, and we had a case where a patient came in with nothing but fever and diarrhea, and the next day developed respiratory symptoms. So on the first day, the patient's not isolated, because back then when that patient came, they didn't realize it. Now we do. Also, loss of taste and smell can be a presenting symptom that has nothing to do with the respiratory tract. We now have the first case of encephalitis, just pure brain involvement. So it's an evolving process. That's why it's called the novel coronavirus, because it's new.
And then chances are it'll continue to evolve, right?
The knowledge hopefully will certainly continue to evolve. The other thing that's evolving is the intensive care unit physicians' ability to treat this thing, realizing that some of the paradigms that we know from treating what's called adult respiratory distress, I don't want to get too much into the technical stuff, but the adult respiratory distress syndrome, which was present it's just present there. It was part of SARS, the way you treat these patients on the ventilator is different than previous ways it was treated. The paradigm is shifting to how the pulmonary doctors and the respiratory and the intensivists are going to be treating this as far as on the respirators. So all this is evolving.
Well, hey, so during the Civil War, surgeons transferred knowledge when they would run across each other. And because these guys went, it didn't depend on what side they were on. If they came across another doctor, chances are they talked about what was working and what wasn't. So how is that communication with modern technology? I can't believe that is there an organized system for these doctors once they innovate and get better results to talk to each other about it?
Yeah, before I answer that, going back to the Civil War, they actually both North and South had medical journals, which came during the war. So they were able to communicate, things were slower back then, but you could communicate through the journal articles even back then about what were the best practices. The controlled studies of how you treat, you've heard of Benjamin Howard, how you treat sucking chest wounds. He did a controlled study on that. That got disseminated.
Yeah, and then we can tell our story because of those journals and because of the surgical history of the war, and thanks to William Hammond again for that innovation in that order.
But what we're talking about here is actually at the time of the war. The Mishwar came later, but as far as what happened, doctors being able to communicate to one another, even Union doctors to other Union doctors, thing is so spread out, you're not going to encounter a lot of your colleagues. And the Southerners, the same thing.
So how's that working today? Is there a system in place, or is it informal?
Yeah. No, what you suggest is right. What I'm seeing so far is people communicating, by email, texting, forums on the internet, that kind of thing. Ultimately, also, there's internet sites, things that I actually am using to prepare these updates, things like Healthio, Medscape, infectious diseases. These are things which I subscribe to before any of this, where you disseminate information among infectious disease physicians. We're not having any face-to-face meetings anymore like we used to, but that kind of thing and technology really facilitates that. So, and these are things and I've seen I'm talking about how the pulmonologists are treating patients on the ventilator. I saw a guy who's an intensivist just put a video up telling other pulmonologists about what he's observing. He said there's something different about this from previous. He says these patients look like patients with high altitude sickness, if you know about that. where instead of the lung membranes becoming thickened, they're not. So putting high volumes of oxygen at high pressures is not what you want to do for this, which is previously how we treated it.
Amazing.
So another kind of quick question on this that I'll take that we got from the comments we talked about some of the journals that are being published, as well as the medical and surgical history of the Civil War during the 1860s. We'll let you know, Andrea, that you can find many of them online through Google Books, through archive.org. The medical and surgical history I just dropped into the comments, so you can find that. Many of those are searchable online. You can find them accessible via the internet.
Hey, John, I want to jump back to the virus itself. You were describing maybe some changing symptoms. Is it constantly evolving to where there might be new symptoms?
Well, I'm not sure they're new symptoms, Dave. It's that people, the more patients they see, the more atypical symptoms they see. It's like any disease, if you see enough of it, you're going to see atypical presentations. That's not unique to this virus, or even in other infectious diseases or other parts of medicine, even that the more you see, the weirder presentations or the more atypical presentations start being reported, like the encephalitis. I think this was like the first case. So they now think that the virus, in addition to entering your body through the respiratory route, can enter directly into the central nervous system, probably up through the nose, which is why you lose your sense of smell in some cases.
Good grief. Jumping back to the only other thing I didn't bring up about the similarities between the Civil War that I had on my notes here was I heard the other day, as they're outfitting, it's obviously they're taking over convention centers for temporary hospitals for overflow. But in order to do so, the Army Corps of Engineers has come up with two kind of standard layouts, and one is COVID layout and the other is non-COVID layout. And that harkened again back to the Civil War.
Yeah, absolutely. And speaking about how the layouts, some of this stuff comes from working with other things like the few cases of Ebola that we had. The NIH treated one patient, and they treated somebody in Nebraska, and we have before any of this COVID stuff, there's certain designated facilities in the country to treat. Nobody anticipated on this scale, so that they're smaller. But NIH is one. University of Nebraska happens to be another one, where they're already set up with these kind of isolation facilities pre-positioned. It's obviously not adequate for this, but that kind of thinking was there.
So let's jump back to your Facebook column that you update at least daily. Talk to me about some of the other questions that people are asking you all the time. I mean, you've got everything up there, man. It's great. You put up some age ranges the other day.
Yeah, one of the things that somebody asked me about, what about age? We know in general age and underlying conditions support this, or the older you are and more underlying conditions make the thing worse. I have some people in the audience who are very smart people and have sort of engineering kind of minds and so forth. And so I got one of the guys that analyzed looked at the data, and he says, it seems to me that while younger people are getting the virus more often than older people, the older people are getting more serious illness and dying, which suggests that the younger people are not following the recommendations as stringently, are getting the virus, not getting as sick themselves, but giving it to older people who come in the hospital and then die, which is a good observation. And he said, tell me hopefully I'm wrong. And apparently I don't think he's wrong. I think that probably is what the case it is. You remember seeing that in Florida before, wasn't that long ago. I think it was Clearwater Beach with all the kids on spring break. While other parts of the country were shutting down, you see all these kids in Florida on spring break.
Yeah, and which was a travesty, especially if these numbers hold true that you're finding out.
Well, it harkens back, and the same is true. Louisiana is a hotspot. I went to college in New Orleans, and all of a sudden, Louisiana became a hotspot in the city of New Orleans. And what happened is Mardi Gras, in February went on as planned. And Mardi Gras is just the perfect place to transmit this virus. So their surge happened 13 days after Mardi Gras. Yeah. And it harkens back to 1918 when the city of Philadelphia was having a war bond parade with 300,000 people. And the public health people tried to get them to stop it. Politicians wouldn't, and they had 12,000 new cases after that.
Yeah, we've got our resident 1918 pandemic man, Jake Wynn, and a plug for him. You should check out his blog, which is Winning History, WYNNING.
Yeah, I know it. It's very good.
Yeah.
Oh, thanks, guys.
Well, if you're working on a pandemic, you should be able to share that work on that pandemic. Hey.
Well, I also, if you're talking about books, I recommend John Barry's. I'm from Tulane, and so is he. Is The Great Influenza.
Fantastic book. I'll drop that into the comments here shortly as well. I can also recommend that book as the go-to on the 1918 influenza pandemic.
Hey, John, so masks, let's talk about that. I just recently got my first one made, and thanks to our friend Sue Markey. So talk to us about masks.
Well, yeah, by the way, that's another frequently asked question is mask. Mask, as you know, is an evolving thing. Like everything with this virus, the more we know, the recommendations will change. It's not that doctors are stupid, and just before I answer specifically, people say, why should we trust you? You keep changing your recommendations. If you didn't change your recommendations, you shouldn't trust us. If you don't evolve your thinking based on the data, then there's something wrong. You want to change. Lincoln was a prime example of a guy who changed in his thinking. So that's an invalid criticism. Okay, masks. What we used to say was masks do not prevent you from getting the virus, which is true, but it has to do with how the virus is transmitted. The WHO and the CDC, and I'm not sure that they've changed their website on this, said the primary mode of transmission is through droplets, which means small particles, 5 microns or so in the air, which are liquid particles, which when coughed out, travel about 3 feet and then drop 3 to 6 feet and then drop to the ground. By the way, that's where the 6-foot social distancing comes from. Gotcha. The fact that those droplets travel no more than 6 feet. So that's where that 6 feet, if people ever wondered where the 6 feet, they didn't just invent that out of nowhere. Now there's been some experimental studies and some observational work that says, like, for example, seasonal influenza is transmitted by droplets and by aerosols. What that means is particles which are coughed into the air travel a greater distance than 6 feet and then linger, in this case, up to 3 hours in the atmosphere, which means you can go into a room with the virus, cough, go out, another person comes in and could theoretically then contract the virus without ever being in contact with you. This indeed is how measles spreads. That's why measles is so contagious. So if that's true, that there's aerosolization of the virus, that is the rationale for why when you enter a building with a confined space, such as a grocery store, a pharmacy, a gas station or building, inside. And we're not talking about outside in the mall in DC. You theoretically could then, if you're not protected, transmit the virus, catch the virus to yourself or contract the virus. So the recommendation would be, and we're not talking about in the hospitals, because if it's true in the hospitals, then the hospital workers really need to wear N95s for even when they're not in direct contact with patients. Masks, we're talking about number one, N95 for the public, no way. People who are going online showing their N95 masks, I say what you got to do is donate them to the hospital, not broadcast how great they look on you on the internet. Beyond that, surgical masks are about 90% effective in filtering the virus. And then I've posted this, a list of materials that are effective, things like vacuum cleaner material and scarves, etc.
Yeah. So is it really about me not giving it to someone else?
Yes. So the most effective part of the mask is prevent you from transmitting it to someone else rather than you getting it, because there's no perfect mask to keep you from getting it, which is why the recommendations were not to wear masks. There is some protection. The other thing a mask does, it prevents you from touching your face, which everyone does. It also prevents if you cough, and even if it's droplets, if those droplets land on a surface and then it contaminates the surface, and up to 3 to 5 days, depending on the surface, someone touches that surface. So it does serve that purpose as well. Yeah. But if you think you're wearing a mask to prevent you from getting infected, that's not really the deal. It's to prevent you, if you're an asymptomatic carrier, or it's early in your disease, from giving it to someone else.
Gotcha. All right, I have 2 questions here going back to the Civil War. Both are kind of hospital related. One is from Brad Stone. Hi, Brad. Thanks for watching. He's one of our great docents.
Hi, Brad.
If you haven't watched our series of videos on the U.S. Navy in the Civil War, those are on our Facebook page and as well as our YouTube channel that Brad has done. Those are fantastic. But his question is, how often were wards designated for the treatment of communicable diseases in Civil War pavilion-style hospitals?
Well, I think the best example would be pox houses, which were one of the things they did try to do in the war. Is when you had smallpox was not a huge problem ongoing. There were outbreaks. There was a big outbreak in '63 of smallpox around the time of Chancellorsville. But when you have smallpox, they did recognize the contagion of smallpox. So they had what were called pox houses or pox hospitals, where they would put all the smallpox patients into the same place. As far as isolation wards type of thing, they didn't really do. One of the things they did recognize, though, is that to prevent the spread of things like hospital gangrene and erysipelas, if you did not share dressings, bandages, that kind of thing from patient to patient, but you gave the patient his own, or you washed him off before giving him to the next patient, especially, but not allowing him to share, that worked. So they did indeed recognize that. As far as like saying you have erysipelas, you need to go to a separate ward, they didn't really do that. They only did that for, I think, for smallpox.
Okay, second question is from Andrea. Were soldiers with illness kept from soldiers who were wounded?
Not in the, are you talking about general hospitals? If you're talking
I would presume she's talking about general hospitals.
Yeah, they really didn't. Some hospitals like Armory Square, though, had separate ward for officers. Officers generally got better treatment than the enlisted men. If they took over a farm, for example, as a hospital, the officers got treated in a farmhouse, the enlisted men got treated in a barn. It was the 19th century way of thinking. But as far as isolating sick patients from wounded patients, they didn't really make a formal attempt in the general hospitals to do it. Obviously, in the field hospitals, it's almost impossible to do that.
Hey, John, listen, I can't thank you enough for doing this. And I wanted to let people know that if you do want to follow John, you look him up on Facebook, John Willen, Willen, and Jon as John. And it is a private personal Facebook account. So when you request, it'll be a friend request. And then I think John said he's just thrilled with the number of friends he's getting now. So
well, I've had almost 400 new friends here.
Yeah, well, I tell you, that was a big reason. I mean, I'm telling you, I love the updates, and I gave it to my daughter who is constantly getting false information everywhere and panicking, and it's refreshing to get accurate information from you, and you take great questions and take the time to answer it. So I know it's probably taking you more and more time each day, but we greatly appreciate it. And
I will let the audience know as well that I dropped that
Well,
profile information
you know,
into the comments.
go ahead, John.
No, I mean, it's funny because to do it right, it takes more and more time. But as you know, I was forced to do this on the phone. And while we've been doing the interview, I've had about 5. When you get a new friend request on Facebook, you get a notification. I've had like 5 notifications since we've been talking. New friend request.
Great. Well, watch for I just like Jake said earlier. The only way we can do this kind of programming and stay working, since we don't have admissions here at the museum, is to ask you guys for memberships and for donations. And we will definitely have John on again, and probably to do his talk on Dr. Semmelweis, among other things. And I'm looking forward to doing some more of these Hope Offer History kind of discussions. I think we've got Jim Broomall from Shepherd University and the George Tyler Moore Center for Civil War Studies in the queue. And I'm also going to reach out to former executive director of the National Museum of Civil War Medicine, George Wunderlich, who's down at the U.S. Army Medical Museum, for a great conversation. And he's always got some great insight to these kind of things.
Well, yeah, I'm glad you mentioned George, because when I started in this, he was one of the guys I learned a lot from early on in my career in Civil War medicine. So.
Well, and I remember meeting you, John, on the first conference I went to, and you were very welcoming and just hungry for knowledge, and I am too. And this to me is a great way to talk about Civil War medicine, but really to give information on what's going out in the real world today, which is really important. So thank you very much.
Oh, it's my pleasure. Thank you for asking me.
All right, everybody. So we're going to, we've got to most of the questions, so we're going to drop off now. Do want to say thank you so much for watching. We'll be doing more of these videos throughout the next couple of weeks as this situation continues to go on. But I do want to thank our my wonderful guests here. As the leader of this Zoom stream. Thank you so much for David and John, Dr. Willen, being willing to come on and chat today and have this discussion. Thank you all so much for those questions that you asked, and look forward to seeing you on future streams. I'll reiterate what David said as well. If you are enjoying these streams, like what we're doing with this digital history initiative, please, even small donations, assist if you don't want to go in for the full membership, but every little bit helps, and we're just so thrilled that people are tuning in. So thank you all so much for watching, and until next time, this is Jake Wynn from the National Museum of Civil War Medicine signing off with David Price and Dr. John Willen. Thank you all so much for watching.